I'm wanting to review with you different treatment options available for depression in teens and children. So, first, we have to understand that depression in teenagers and children is becoming much more common. Now, there's a lot of different reasons for this, which we're not going to fully go into those, okay? But it can do to different things, right? And we're seeing divorce rates going up, we're seeing bullying going up, we're seeing a lot more cyberbullying, a lot more emotional stressors that kids have never had to deal with before. We're seeing more technology that's preventing the brain from developing in the way it should. We're seeing a lot of things that ultimately takes away from resilience of the brain developing right. And as the brain doesn't develop right, susceptibility to depression increases, which means the likelihood of depression also gets higher. So I'm going to review with you 3 different therapies that should be considered for depression in both teens and children. And I'll kind of separate which one I think is better for one versus the other. Now, what I'm going to do is, first thing I'm going to do is share with you my screen and talk about where are we currently at with medications in children. So this was a presentation I gave to a bunch of providers. And what they looked at was they did a full analysis. Okay, so what a meta-analysis is, this is when they look at multiple research studies. It's not just picking one or two. They look at usually dozens, if not hundreds of studies. And what they found was the change in children's depression rating scale was only 0.12 with antidepressants. They characterized this effect was very small and less than what has been reported in adults with major depressive disorders. Now, even with adults, there's a high rate of what's called medication-resistant depression or treatment-resistant depression. So it's even worse in children. And this is a big issue. So the days of thinking Prozac, Zoloft, escitalopram, Cymbalta, all of those are the cure, that's long past because it doesn't meet the need for most individuals. And so we've got to appreciate the fact that that's not where we need to be. So first thing we want to talk about is, once again, depression is a complex neurological issue. So if we can impact the neurology in a positive way, we can change what's happening. So let's talk about first transcranial magnetic stimulation. Okay, so how many of you are familiar with transcranial magnetic stimulation? How many of you aren't? Think about that for a second, but then I'm going to review with you, like, what is it? What is it not? So you've got a good idea. So transcranial magnetic stimulation, this is a device. Now, I'm going to share my screen with you again. So transcranial magnetic stimulation, so you see this coil back there. Now this delivers magnetic pulses. So it's a way of non-invasive brain stimulation that ultimately changes the way the brain's connecting. So normally for depression, it's applied to the left frontal area. For anxiety, it's applied to the right frontal area. Even ADHD, it's often applied to the right frontal area. But the way it is controlled determines whether or not it facilitates connections in the brain or it inhibits. That's critically important. So it's not just about the placement, it's about the programming that matters. Now, when we look at the research for transcranial magnetic stimulation, it's been researched down to the age of, I believe, 6 is what it's been researched down to. So when we say, okay, we've got children, we've got teenagers that are dealing with transcranial magnetics, or with depression, could they use it? The answer is yes. Now, my specific favorite is using theta burst stimulation. Okay, theta burst stimulation, this is a very quick treatment for depression. And I often combo the depression protocol with the anxiety protocol, which is done in 30 minutes, versus there's a traditional TMS protocol that's closer to 25 to 30 minutes, and it's only for depression. It doesn't do anything on the anxiety side. But it's also not as comfortable. It's a lot more discomfort for them. It also requires more sessions, but the results aren't any better. So, and that's what this is shown down here. So the incidence of adverse effects was really no different. And what they saw, depression rating scales, theta burst versus RTMS produced no statistically significant difference. So they're like, look, you know what? The results aren't different. So there's really no reason to do the one that's more discomfortable, more uncomfortable, also requires a lot more treatments to get to the same point, especially when we're talking about children and teens where discomfort is everything, whether or not they try it or just stop. So that's one. Next, let's talk about neurofeedback. So neurofeedback is becoming more and more popular. Now, what neurofeedback is, ultimately, you wear this cap and it's going to monitor your brain waves in real time. Now, one of the things you can see when you do this initial, we call it brain mapping, or QEEG, quantitative electroencephalogram, is you can get excess. So this is the left side of my brain. So you can get some excess alpha on the left compared to the right, or even some excess theta on the left compared to the right. And the left side of the brain is known as more of the positive side of the brain. So if you excess of those waves, which tend to slow things down, you slow down the positive side of the brain, and theoretically, it can lead to depression. That's one of the thoughts behind it. So with neurofeedback, because it's monitoring your brain waves in real time, you then get this feedback from the computer to let you know if you're where you should be. Some, it's just a sound. Others, it's visual. For kids, we often do things where they're watching a YouTube video, but we've got a program that actually dims the screen, reduces the sounds if their brainwaves aren't where it should be. So they know, like, okay, you know what, hold up, let's kind of get it in sync. Now, part of this is done through like subconscious programming, where the brain intrinsically starts craving it. It's based upon conditioning in psychiatry, where you look at what's called Pavlov's dog, where ultimately they train the dog to salivate every time it heard a bell because it was just conditioned to that. The same thing is true with neurofeedback. It's about causing neurotransmitter release to make connections based upon a stimulus. I see neurofeedback can work really well in kids. As we get into teens, it really depends upon the personality. There are some teens that do really, really well with it, and there's others that don't do as well. So those are the two that I really like for both teenagers and little, younger kids. Now, when we talk about teens and we ignore younger kids, there's another therapy that really should be talked about. And that's where I'm going to go to next. So once again, I'm going to go back to that research article or that presentation I gave to a group of providers. And this is ketamine. So ketamine started in the world as in anesthesia and postoperative pain management. And then they ended up finding out, given at lower doses than they use in anesthesia, it worked really, really well for depression. So ultimately, it works on the neurons and it has rapid antidepressant effects. It stimulates connections in the brain, increases plasticity. So plasticity is the ability of the brain to change. So there's a lot of nuances in how ketamine has to be done, plus other things around it to allow for best results. If not, don't expect the best results. And that's why a lot of people, unfortunately, don't get lasting results with this if it's not done right. Also, though, anti-inflammatory. So it does help with some of the inflammation, because inflammation is a big driver of depression. Next, we saw that ketamine actually protects the brain followed chronic stress, which ultimately can lead to depression, specifically when it impacts the hippocampus, amygdala, and prefrontal cortex. Ultimately, hippocampus is memory and learning. Prefrontal cortex is attention, impulsivity, and things like that, concentration. And then amygdala is the fear and aggression response and the way your brain records it. So here was a research study. Now, this was done out of Yale. So they did IV ketamine. I like injectable better personally, but they did 13 through 17-year-olds. Now, they found that it was well tolerated, helped depression. So yes, it is something that can be done. Now, below that age, is this something that I really recommend for kids that are younger than that? Normally, I don't. This is something that really needs to be talked about with your provider. There are other options that should be considered first. Now, there may hit a time frame where it's like, look, you know what? It is worth potential risk for it. But ultimately, teenagers, childhood depression, ketamine, transcranial magnetic stimulation, and TMS are therapies that should be considered. All of those can work really well for teens. for children, once again, try to avoid ketamine. Now, there are some nuances as to who does better with what, specifically for teenagers. And that's where having a provider that knows and widely uses all of these can really help you decide which one's the best, because it's going to be based on the history as well as other factors that could impact it. So hope you found this information useful. If there's something else you'd like me to do videos on, please comment and let me know. And if you'd like to get in contact with my office, here's how.